We are live now. You can start the session.
So good evening, everyone. I welcome you all to this second webinar of the series of Mastering Techniques in Cataract Surgery. And today we will master incisions and hydroprocedures. So before beginning, let me just introduce you to the YOSI panel. We have Dr. Devakant Mishra sir as our president. Dr. Sonal Kalia ma'am is our immediate past president. Karan Bhatia sir is our vice president. Nilesh sir is the secretary of YOSI. Aditya Sethi sir is a treasurer and Prasanna sir is a joint secretary, and we have 20 executive members in the team as well. So this is the cataract focus group. Along with me, we have Dr. Aishwarya, Dr. Anup, Dr. Abrar, Dr. Nishi, and Dr. Soumya. So earlier we had conducted cataract chitra competition, and we had our first webinar of the series, Mastering Capsulorhexis, last month. So today we will master incisions and hydroprocedures, and we are extremely privileged to have with us our expert panelist, Dr. Deepak Megur sir. By watching his videos, we have all learned, and we are still learning all the techniques and complications. He is a consultant at Megur Eye Center, Bidar, and he is delivering cataract and glaucoma services. He is specialized in complex cataract surgeries and has presented scientific research papers at various national and international conferences. He has been invited as faculty in many state and national level conferences and has also been an instructor in IC courses in various international meetings. He has multiple publications in national and state peer-reviewed journals. Sir has bagged many awards. Some of them are Bashir Mekri Second Best Paper Award at Manipal, M. Joshi Overall Best Paper Award in 2008 at Shimoga, Best Paper Cataract Session at AIOC Kolkata 2009. He has won multiple times the Best Video Award at Udupi Glaucoma Society of India and at Karnataka Ophthalmic Society in 2013. He has received the Best Paper of the Session at APACRS at Jaipur and has been awarded with Ratnakar Mulatpatan Award at Udupi and again the Best Cataract Surgery Paper Award at Bangalore. We are extremely delighted and excited to have you, sir. So we have our conveners for this session. We have Dr. Anujit Paul, who is a consultant at Cataract and Vitreoretina Services at BBI Foundation, Kolkata. He's also an assistant professor at Ramakrishna Mission Seva Pratishthan, WIMS, Kolkata, and he has been a recipient of IGO Platinum Award as well as TNOA Gold Medal. He has multiple publications in national as well as international journals and 2 book chapters also. He's also the retina section editor in Tamil Nadu Journal of Ophthalmic Sciences and a subcommittee member of Ophthalmological Society of West Bengal. We have Dr. Nilesh Kumar sir, who is our own secretary. He's the medical director at Madhvi Nethralaya, and he is the innovator of DIGS and DIGS Pro. He has multiple national and state awards and more than 96 peer-reviewed published articles. He has delivered multiple papers and invited lectures and live surgeries in various national as well as international conferences. He is the current secretary of YOSI and ex-joint secretary of YOSI. He is also an executive editor of iQuest, assistant editor at AIOS Dynamic eBook, and chair of communication Retina Rocks Retina World Congress. He has been the convener of transfer skill courses at AIOC from 21 till now. So I welcome you, sir. So before beginning, let me just I request Dr. Nilesh sir to address all of us. Thank you.
Thank you so much, Dr. Lippi. I think this is a great initiative that you have continued with the second episode of this webinar that is coming on time, and a very nice idea to like take a single step and to discuss it at length, because often if when we start any FACO webinar, most of the talks are on nucleus management and chopping techniques. So this is a very good segue to get the basic skills right, and we are extremely privileged to have Dr. Deepak sir. Thank you so much, sir, for joining us and blessing us. We are looking forward to your expert inputs on how to be better at what we do. Thank you. Looking forward to a great webinar.
Thank you, sir. So just I would like to thank Dr. Anujit. It was actually his idea to start this webinar series. So thank you, Dr. Anujit. We are also having resident corner. We have today with us Dr. Juhi, who is a second year resident from ESI Medical College, Faridabad, and Dr. Neil, who is a second year junior resident from RIU, Chennai. So they will be joining us and will be attending the whole webinar and will be directly asking their doubts and questions from the expert panelists as well as the speakers. So I would like to request Dr. Deepak sir to address us and before we begin with our first talk.
Well, it's a great initiative. Thank you for having me here. I think we can go ahead and start the session.
Okay, sir. Thank you. So our first speaker is Dr. Bhavya Gukani. He is a consultant at ASGI hospitals. He is also our executive member of YOSI. He has served as head ophthalmic surgeon at LB Badiani Trust Hospital, Gujarat, and the Lifeline Express. He is also the high volume surgeon and also not to forget our own stand-up comedian and TEDx speaker. So we welcome you, sir. Over to you now.
Thank you. Am I audible?
Yes, sir. You're
Yes.
audible.
Okay. So, is my PowerPoint presentation visible?
Yes, you can make it in full screen.
Yeah, it's already full screen. Is it full screen for you?
No, it's not for us.
Just a second. Is it now?
No,
Not
I think you need to stop and reshare again with the
you.
entire screen.
Second. I'm sorry for. Am I better?
Yes, now you can press full screen. Yes,
Yeah.
now
Is
it's
it?
full screen. Yes, you can start.
Good evening, respected seniors. Hello, sir. Hello, and it's an incredible topic that brings us here. Understanding and mastering incisions in cataract surgery. Basically, when we talk about this topic, I when I was approaching it, I thought that I'll keep it a little practical because it bombards you with a lot of theory in such a way that we have a lot of young ophthalmologists who are around. And as sir rightly pointed, usually we talk about most other steps, and we land up not talking about what is the cause of the entire domino effect. So yeah, here we are, incisions in cataract surgery. I have tried to keep it as less text toxic as possible, and maybe I'll throw some light into some of the practical aspects, things that bothered me in my entire journey. I mean, it has just been 2 years that I've done my secondary DNB, and I feel that every young ophthalmologist who is setting out his journey into understanding the incisions must take care of these few points. So, of course, there's no financial disclosure, there's no financial interest around. Why is the incision important? Because it is the main thing, right? It is the entire entry into the anterior chamber, the entire fluidics, the entire ease of surgery. And looking at one side, when we talk about the positive aspects, that is all fine. But then when you are talking about the repercussions of a bad wound, everybody sitting here would understand that one bad incision and the entire surgery you're going to curse yourself. So a little touch of ANAT, which most of us are probably already aware about it, the surgical limbus, the anatomical limbus, because there has always been a lot hullabaloo about where should an accurate incision be made. In the subsequent slides, I've tried to cover it. Just a small amount of ANAT, which is already on screen, and I might rush through it a little early. So the first incision, so how I've planned the flow of my event is I'm going to talk about the side port and then rush to the main port and then try to elaborate the other paradigms of what all comes under a good main port. So the first thing that you talk about is a side port, which is also known as a paracentesis. It is important because it is the initial pouring into the eye. The initial steps of the cataract surgery are through it. And of course, for somebody who uses bimanual irrigation and aspiration, these side ports are very important. A small addition is that a side port is usually done with a 15-degree knife for an MVR blade, and it's usually 1.5 into 1.5 clear corneal, be it in an SICS, be it in a phaco. My presentation would be mainly encompassing more about phaco, and in the part of the discussions, I would cover some amount of SICS explanations as well. The practical tips which I realized when I was coming across is most of the times the beginners, as any resident, any young ophthalmologist who sets his journey out in cataract surgery, gets the side port first. And the most important part when you talk about a side port, there are two things that come into action. One, the way you enter the side port, and second, the second instrument which you use. A lot of institutes, advocate using a bud to take care of the eye. Some institutes or some mentors advocate the use of a tooth forceps, a limes, whatever you are comfortable with. But yes, a side port is important. One practical tip that I came across is whenever your side port is a little too big, ophthalmologist, a phaco surgeon, and SICS surgeon tends to press the posterior lip more, which causes a lot of visco to come out. So one tip is don't make your side port too big, don't make your side port too long, because you might also realize in your course of phacoemulsification that whenever you're using a very long side port for your left hand, because I'm a right-handed surgeon in which you're holding your chopper or you're holding your dialer, if the side port is too long, what happens is it lands up pressing your that side of the cornea, which eventually lands up obscuring your view. Along with this, a too short side port or a too steep side port or a too wrongly placed side port towards the corneal side or towards the scleral side eventually can middle up with iris as well. So this is the practical tip which is related to the same. Now the next main thing is what I talk about is the main port. And mostly talking into convention or talking into the current era, SICS is when you make a scleral tunnel and then enter into the anterior chamber. And in phacoemulsification, most like if the world is divided into two, it's usually scleral phaco as well as clear corneal incisions. In the subsequent slides, I would try to put some light into both of them. The main port, eventually, when I talk about credits to IVK for this particular table, whenever you are talking about a scleral tunnel incision, I found this table very helpful for the entire understanding part of the juniors and the budding ophthalmologists. What I realized is the scleral tunnel incisions have very lower rates of endophthalmitis as compared to clear corneals. Of course, in case of SICS, because we already are aware of the benefits of SICS over phaco, etc., etc. The scleral incision is the one which we usually do. One of the things that is more important is in case of microcornea, it is preferable, and in case of low endothelial count, it is already it's always a very good thing to go for a scleral tunnel incision. The disadvantages will obviously be that increases the chance of bleeding. There's a little messy work field that is there, and most of the people would come across hyphemas if a badly done scleral incision is made. Contrary to that, when you talk about clear corneal incisions, yes, it is self-sealing. It is a sutureless wound. It has a shorter procedure time. It has a beautiful visual recovery. Of course, it is used as a refractive tool for pre-existing astigmatism. It can be used for topical anesthesia because we know that scleral incisions could be painful. So when you talk about topical, relatively clear corneal gives a better control over your patient and less pain to the patient. Of course, there is little less bleeding as compared to virtual minimal bleeding as compared to the scleral incisions. But at the same time, we have also observed that a downside or a disadvantage of these clear corneal incisions, which we fail to understand, is high risk of endophthalmitis, a huge chance of wound leaking. So the tips that always, check your incisions before, leaving the case, or make sure that they're not leak incisions. They do induce irregular astigmatisms, which is very important because cataract surgery is no longer only a visually rehabilitating surgery. It is also a refractive surgery in this current era. Of course, descemet detachment is a bad problem that comes out with these CCIs. Yes, and corneal erosions and hypotony are the few. So now we'll just dive into the entire, description about how these subparts about these incisions are discussed. So the first which I discuss is the location of the incision. So on the basis of location, be it SICS, be it phacoemulsification, we usually, the beginners, they debate between two things, dependent on how their mentors are. Jumping into the practical aspect, people tend to debate between temporal incisions versus superior incisions. I personally have been a fan of temporal incisions because, well, easy access. The distance from the periphery to the visual axis is more. Of course, in terms of, there's no need of bridal sutures. It prevents pooling of blood. And at the same time, it's easy to maneuver. At the same time, in case of superior incisions, yes, when you're talking about a tunnel, because you are entirely dissecting the sclera, the superior incisions of entry are the one which are preferred in cases when you're doing SICS. And in case of with the rule astigmatism, it definitely reduces. Apart from it, the incisions are further subdivided on the basis of scleral, what we were talking about. The scleral incisions are usually 1.5 to 2 mm posterior to limbus. They have usually 3 dimensions, which we talk about. They're 3 mm wide in the center, and then they'll end up flaring out. And the others are limbal, which we will discuss further. And the third ones are the corneal ones. One thing that I felt better to cover in this particular this sequence is the surgically induced astigmatism. The temporal incisions, yes, they are better than superior ones because there's a closer proximity of the superior limbus to the central visual axis. So in cases of temporal incisions, the surgeon has a better view. Both of them, it has been observed that around 8 weeks post-op, the changes in the nasal approach are greater in the early post-operative period. Finally, after all, it is the surgeon's preference, because if the surgeon is not comfortable at the end of the day, everything is at ruins. Superior incision is more recommended in cases of Witherul astigmatism where it is greater than 1.5 diopters, and whenever the steep axis is at 90 degree. And a temporal incision is recommended where the steep axis is at 90 degree, but less than 1.5 diopters of an astigmatism is seen. Nasal incision, though difficult, is recommended for less than for greater than 0.75 degree of astigmatism and steep axis at 180 degree. Of course, all of us are doing clear corneal incisions, paired opposite clear corneal incisions. Whenever you feel that the patient is opting for a non-toric one and the patient wants a better result, you can always slice in a small main port entry and make a small clear corneal incision. The practical trivia in case of a badly located incision is always one, it is based on the surgeon's factor. In my own career, I have realized that badly located incisions, especially in cases of deep socket, especially when you are a beginner, it does matter. So I used to be a little fearful when I used to shift or when I used to be expected to shift at a particular side. Apart from that, yes, if there's a particular small corneal opacity at that particular area, then you should be mastering all the incisions at different locations. So that's the practical trivia. The size is the second thing that I would like to discuss. The width of the phaco incision should be matched to the gauge of the phaco probe, the irrigation aspiration tip, and the IOL injector. Based on the classic current phaco incisions range between 2.4 to 2.8 millimeters. And on the basis of that, the foldable IOL cartridges are also involved. But yes, if you're planning to implant, which a lot of people discourage, if you're planning to implant a larger IOL, of course, you have to increase the size of the incision in case of phacoemulsifications. An incision width of 1.8 to 2 mm has small SIA with no difference in visual acuity. And the more you decrease the size, of course, the astigmatism is going to reduce, but there has been a negligible effect between 2.2 and 1.8 mm of astigmatism. Uh, Practical trivial rush, the shape and the form. This is what the SICS incisions would, mainly be discussed. Whenever you're talking about SICS, a lot of other incisions have been described where they are, classified into convex, straight, frown, chevron. J-shaped and trapezoid. Somehow discussing each of them is beyond the scope of our time allotted, so I'll rush through it. Badly shaped incisions have a very big problem. When I talk about shape, if my incision is particularly ragged, the shape of the incision is not favorable, it leads to a lot of problems. So when we are talking about the clear corneal incisions, we realize that there are two lips that we talk about. There is an outer lip and there is an inner lip. Whenever the inner lip is badly placed, one favorite thing that I've heard from a lot of my seniors say it, that a lot of people have this habit of doing a dimpling movement. So whenever you are making the incision, the rule about a clear corneal incision is that it should be, the first time you go, it should be parallel to the iris. So whenever when you're trying to put that dimple and you're trying to enter that particular incision through the anterior chamber, it ruins up the inside of that particular incision. And that's why they say that, you enter it straight. So that's the practical trivia of that side. These are the architecturally based different incisions which we talk about. The first figure we show it as the uniplanar corneal incision, in which we're putting a single stab incision. The second one is a biplanar one, and the third one is a triplanar one, which it's a single straight incision with another second easing out and the third entry which you go into. Irrespective of any planes that you make, the basic rules of incision formation, that it has to be watertight, it should be having oppositional margins, it should be hydrated properly. All these common rules will apply to all the incisions possible. And now when we talk about bad incisions, this is what is practically related. I usually talk about bad incisions in term of domino effect. There are two. There is a practical troubleshooting, and the second is the anatomical troubleshooting. When you're talking about practical troubleshooting, what happens is, if your incision is bad, your incision is anteriorly placed, your view relatively, gets a little messed up. A posteriorly placed incision, like a really posteriorly placed incision, which you did not want it to happen, what it lands up doing is it tends to press your posterior lip more, and eventually your AC will keep on fluctuating. And these tips are, I feel, very important for the freshers, because this is what they are all struggling against. Another practical thing that I also realized is, whenever my incisions were too long intracorneally, of course the chances of desmet detachment, of course the chances of corneal edemas, etc., are more. So these I describe as the practical troubleshootings, that is based on the surgeon's factor, his view, his ease of operating, etc. And the anatomical troubleshooting is, of course, ignored conjunctiva. When you're talking about bad incisions, when you're ignoring the conjunctiva, it's going to cause a lot of bleeding. It's going to give a messy picture, which is not very promising cosmetically for the patient on the next day. It tends to cause a lot of foreign body sensation also. Some amount of conjunctival limbal bleeding is always a good thing, which we have already established that it is good for healing. So yeah, that works well. The second which we talk about is a distraught cornea. So whenever bad incisions are there, it lands up causing a lot of wound burns. Because of frequent movement, that area of the cornea lands up getting hydrated, and eventually that induces a domino effect, right from your difficult steps to being careful at every time you insert your phaco probe, to you trying to do visco, and eventually having these fearful complications like desmat detachment. This is what happens at a cornea level when you are landing up having a bad incision. Injured iris is one of the most common things that happen whenever your incisions go bad, whether it be in terms of its site, whether it be in terms of its length, whether it be in terms of location. It is also the same for SICS as well as phacoemulsification. If you're landing up doing a premature entry, that's of course for the sclera, but these are all incisions which you talk about. So the iris is which takes up the major blunt. If your iris once starts coming out, it's not a bad thing. It's not a happy schedule thing, and it gets messy. Of course, your lens gets malplaced, because trying to insert through a bad incision with your iris coming out is obviously a problem. And finally, it causes a lot of defects to the patients. So holistically, when you're practically replicating what type of incisions you'll be making, when you try to replicate it, when you try to imagine as a fresher that incision is just another beginning step, and you can land up taking it lightly. I'm sorry, it is very, 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 very important, right from your ease of the surgery to the astigmatism, the entire process where these incisions have to be nice. So I think I wrap my talk up, and I'm incredibly thankful to Yosi for giving me this beautiful platform. And thank you so much, my respected seniors, Yosi members, Yosi family, AIOC, for giving me this opportunity. Thank you so much.
So thank you, Bhavya sir, for giving all the practical tips and insights on incisions for cataract surgery. So can you please unshare your slide? Yeah. So we have all gone through bad incisions during our learning. I request Dr. Deepak sir to please give us some insights and tips on the incisions.
I think Dr. Bhavya has done an excellent job. Congratulations. And he has covered most of the things. And I just like to highlight that, don't take the incisions for granted. Okay. So usually, people try to learn the incisions at last. So initially, they learn all the other steps and put the incision last. And if you see, the only difference which we can make out between an expert surgeon and a newbie is the way the incisions are. So of course the lens would be in the back and other things, but the way the incision is designed, you can make out the difference between an expert and a novice surgeon. Few take-home points, first regarding the side ports. So ideally it should be as small as possible because it increases the better performance of fluidics. So the single reason for your chamber shallowing or a poor fluidic performance is the leakage. So leakage predominantly happens from your left side port with the chopper. And as a newbie, the most common mistake most people do is that you keep on pressing on the posterior lip and all this. And there's a reason why you have excessive fluid running out of it. And whenever there is a mismatch between the inflow and the outflow, you're going to have problems. So the most common reason for most complications is poor fluidics. And in that, leakage to the side port is a major issue. So for one suggestion which I would like to give for all the beginners is when in their early part of their career, try to make a smaller side port incision, left side port, which is just good enough to put in or snuggle in your side port instrument. Don't make 1.5 millimeter. To put in your side port incision for your chopper or a Sinskuk, you can manage that even with just 0.9 or 1 millimeter incision as well. Okay. Or even less than that, 0.8 as well. So that prevents your wound leakage from the side port. You can always enlarge this as you start your bimanual I&A. Because the most common source of leakage is excessive pushing down of your side port incision. And that's the reason why the fluid comes out and sometimes the iris comes and sticks there because you have got an excessive leakage. So you can always enlarge the side port incision when you start doing your bimanual IA. See, these dimensions of your incision should match your bimanual IA ports. That is a dictum. Unless or until you start using that, until you reach that step, try to minimize the size of your left side port incision. That can minimize your excessive fluid leakage. Second important point is position of the side port incision as well. It has to be at the limbus, not in the clear cornea. What happens if you move it very into the clear cornea, because you're fearing about the conjunctival chemosis, which can happen if you make it at the limbus or something, you try to make it very much inside. And first of all, you're making a large 1.5 millimeter. You know what? As you go from the limbus to the center of the cornea, the thickness of the cornea decreases. It is inherent strength becomes lesser and lesser. And because you're moving your instrument left and center, the amount of gap which you're going to induce is going to be very high. And that is the reason why when you close the wound, it will take a long time to seal it. So the first common mistake to avoid is don't make it too intracorneal. You have to make it at the limbus. In your worst case scenario, suppose if there is a chemosis, just give a small nick there and you can take care of that. But don't compromise on the position or location of your side port incision. It has to be at the limbus. Simply because anatomy suggests that as periphery as you go, it becomes much more thicker, and that's the reason why it has got better tensile strength to withstand all your maneuvers. And coming to our main incision, again, location is extremely critical. People are so obsessed about clear corneal. It should not be a clear corneal incision at all. It should be a posterior limbal incision only. And ideally, it is best would be to make a triplanar incision. Okay. So, Dr. Bhavya just highlighted that one study had showed that clear corneal incisions resulted in an excessive incidence of endophthalmitis. So it is very wrong for us to just bracket like this. But it was a study which was published in 2000. There was a big fight going on between clear corneal versus the scleral tunnel. The idea is, because cornea is avascular, it takes a long time to heal. Okay, so that's the reason, and the design of the wound is more important than the location, actually speaking. So if you have made a perfectly square incision or a rectangular incision, the idea of wound leak or the microbes getting access into the antechamber is very minimal. So the most common mistake what people do is they make a very short internal entry. That is, the corneal lip will be very small. So on the table it looks fine, but it is not self-sealing. To have a self-sealing nature, you have to have at least 2 millimeter of intracorneal length, and then you perforate inside. So 1.5 to 2 millimeters minimum required. Suppose you have a 2.8 millimeter incision, 2.8 millimeter is the width, and 2 millimeter is your intracorneal length. That has to be there. You don't compromise on that. And again, my recommendation would be like always place your incision posterior limbus. So don't be so much afraid of having a conjunctival chemosis. You just give a small nick there and it will be taken care of. The biggest dreaded thing is you make a very small corneal tunnel and it is at least 1 millimeter into the cornea. That is not a good thing. No, if you sometimes, if you have an opportunity to do a resurgery for some reason, you go and lift those incisions. They can be opened even after 1 month or 2 months as well. So basically, to enhance the safety, we want to have a well-constructed wound which has got at least 2 millimeter of intracorneal length, and it should be placed at the limbus. And too long an incision can cause excessive corneal hydration, and there's a risk of DMD happening in those cases. And too short incisions are avoided simply because they don't have the self-sealing nature. I think that should be it.
Thank you so much, sir. So do you suggest any modifications in the incisions if the anterior chamber is shallow?
I think the and modifications are in few cases. Like, I don't think a shallow chamber warrants anything. But if you're expecting a high pressure scenario or something like an IFIS, in those situations, it's mandatory that your intracorneal length has to be appropriate. You cannot, in other cases, you can get away with a shorter corneal length. But in these cases, you have to have at least 2 millimeter inside the into the eye, the main incision. And for the side port incision, at least 1 to 1.5 millimeter. So when you're expecting a positive pressure, when you're expecting like, an angle closure glaucoma or a short eye or IFS, there is a higher propensity for the iris to come out. In those situations, the most important criteria is to have an adequate intracorneal length. So err on the side of slightly longer tunnels rather than shorter ones in these scenarios. Second, I think just want to add that the role of scleral tunnel phaco. So it is indicated in few cases, like apart from microcorneas, I think in radial keratotomy, in patients who have undergone radial keratotomy, we would like to avoid limbal or even clear corneal incisions. We would want to place the scleral tunnel incision in between these two archaic cuts. Then an extra indication.
Thank you, sir. Dr. Anujit, would you like to add anything regarding SICS incisions? You're mute. Please unmute yourself.
Yes, I'm so sorry. So I think Dr. Bhavya has covered SICS incisions quite well. So in the beginning, when residents are trying to get their SICS incisions right, I think it's very important to measure your incision as well as from the limbus as well as in length. Try to go slowly with steps. I think rushing through the steps is something which residents make a mistake with. And it's okay if you get a premature entry right in the beginning, in your first few steps, there is always a way that you can salvage the wound from there. And we usually start with straight incisions. So if any resident is listening, if you're dealing with harder cataracts, please go for larger incisions. Please always know the distance from the limbus, ideally 1.5 to 2 mm from the limbus. That helps with leakage of the chamber. I think we can move on after that.
Nilesh sir.
I think everything has been covered very well. Bhavya sir has covered it quite nicely. The Oro Lab has come up with a stamp also for SICS tunnel. So those who are in beginning, they can get that stamp to practice. But please don't get too dependent on that, because you need to develop your estimation. So that is just to guide you initial some 5-10 cases if you are like very hesitant. Rest everything, Deepak sir's comments are already there for details. Thank you.
Okay,
Can
so
I
we'll move
add one
on.
more comment on SICS?
Yes,
So
yes, sir.
for the residents, the most common mistake what they are doing is they're not aware of how the internal lip of the SICS incision has to be created. Okay, most often than not, it is only commented about the external incision. It has to be frown, it has to be straight, whatever it is. See, the valvular effect or the self-sealing nature of the wound comes because of the internal lip. So it's mandatory that you have to have an internal lip should be there's a corneal entry. You have got an external entry and you've got an internal entry. The internal entry has to be at least 1.5 millimeter into the cornea, and this distance has to be maintained throughout the span of the incision. So you should have a straight or a frown shaped external incision and a smile internal incision. Okay. So this is what ensures your self-sealing nature and also prevents the wound drift. That's what causes your excessive stigmatism. The stigmatism SIA is dependent upon how you fashion your internal lip. So be conscious, because most people are not bothered about the internal lip. They go inside and extend. When you extend, what happens? The internal lip eventually meets to the limbus. If it meets the limbus, wherever it meets the limbus, your self-sealing nature has gone. To maintain the self-sealing nature throughout, your internal incision has to be at least 1 millimeter beyond the limbus always. So that is what ensures your self-sealing nature.
Thank you, sir. So we'll move ahead with the next presentation.
Uh, Dr. Neil has some doubt he wanted to ask. Shall we take that?
Yes, sir, but sir, we will take the doubts in the end by both the
Okay.
residents. Yeah, okay.
Okay.
Yes. So next we have is Dr. Rakhi D. Cruz. She's a consultant phacosurgeon at Chaitanya Eye Institute, Kerala. She has 13 research publications in national and international journals and more than 20 paper and poster presentations at state, national, and international platforms. She has received the Young Achiever Award by Women Ophthalmologic Society of India. She has received the Best Free Paper of Section in Community Ophthalmology at AIOC midterm. She has received the Best Free Paper Award again in AIOC midterm 2023, and she is also the current executive member of YOSI. She is the president of Young Ophthalmologists of Kerala. She is heading YOSI Conference Connect group currently, and she is the core member and an active member of YOSI socio-cultural group. So I request Dr. Rakhi to please move ahead with her presentation. She will be discussing the clinical anatomy of lens and hydroprocedures.
Thank you, Dr. Lippy. Am I audible?
Yes, you're audible, Doctor.
So at the outset, I would like to thank YOSI for giving me this opportunity to present in this platform, especially in front of Dr. Deepak Mekur sir, whom I adore a lot. Can you see my screen?
Yeah, you just need to make it full screen.
1 second, I'll unshare and share again. I forgot to share the audio also. Yeah. Is it full screen visible now?
Yes, Rakhi, you can go ahead.
Yeah, so I'll be talking about the clinical anatomy of the lens and the hydroprocedures today. So lens, as we all know, it is a transparent biconvex elliptical semi-solid avascular structure which is located between the iris and the vitreous. Laterally, the equatorial zone of the lens projects into the posterior chamber and is attached by the sonules to the ciliary epithelium. So lens is placed in empty fossa, which is called as a patellar fossa. Posterior part of the lens capsule is in contact with the vitreous and is attached to it via the Weger's ligament. And there is a potential space between the lens capsule and the vitreous space, which is known as the Berger's space. The equatorial diameter of the adult lens is nearly 9 to 10 millimeter. However, its axial sagittal width is varying. It is around 4 mm by 40 years, and it can increase slowly to around 4.75 to 5 mm in the extremes of old age. Lens can be classified into a capsule, a lens epithelium, and the lens cells or the fibers. Capsule is highly elastic and it is one of the thickest basement membrane of the body. It is much thicker anteriorly than the posterior capsule. Lens epithelium is actually a single sheet of cuboidal cells. It is mainly seen only anterior. We don't have a posterior sheet of cells because they give rise to the lens fibers. And the lens fibers, these are laid down in concentric layers. Outermost part is the cortex and the innermost core is what we call as the nucleus. Depending upon the time where it has formed, it can be further divided into a embryonic nucleus, a fetal nucleus, infantile nucleus, and an adult nucleus. The tips of the fibers meet those of the other fibers to form sutures. So we have two sutures, a Y-shaped and an inverted Y-shaped suture. So surgically, coming to cataract surgery, we divide it into a capsular bag. Then comes the superficial cortex, then comes the epinucleus, and then the main chunk of the endonucleus. So technique of hydrodissection, this was first coined by Faust in the year 1984. Fine was the person who described the cortical cleaving hydrodissection in the year 1992. He described it as injecting fluid to separate the lens nucleus from the cortex, which help in facilitating mobilization and an easy removal of the nucleus. This procedure requires cortical removal by irrigation aspiration as a separate step. So before you're doing a hydrodissection, what should be there in your mind? You should first ensure that you have a properly sized capsular rhexis. Minimum should be 5.5 to 6 mm. See, if you're having a very small CCC, for example, if it is only around 4 mm, there are high chances that when you are injecting fluid rapidly, there are chances of capsular blowout. And also, it is also important to remove some amount of viscoelastic from the anterior chamber before you do the hydrodissection in order to ensure that you have reduced the anterior chamber pressure. You use a 2 cc syringe with a 27 gauge blunt cannula and place this cannula near to the equator of the lens. So here I'll be sharing a video by none other than our Deepak Meghus sir itself. He is describing hydrodissection procedure very beautifully.
So hydrodissection basically consists of two steps. One is we go and inject fluid from one equator. The second would be to
Is the
decompress
audio
on the opposite equator of the lens so that the bag is
Yes, it's audible.
decompressed. So this completes one cycle of hydrodissection. So you inject the fluid from one quadrant and then depress the nucleus in the other quadrant so that you let out the fluid. So this is one cycle. Now,
So what is said here is you have to go till the equator. It's very important to position the cannula near to the equator itself. If you are going to place it a little anteriorly, you will not be getting a complete fluid wave. So in order to get a complete fluid wave, you need to keep it a little posterior near to the equator of the lens in one pole and then start injecting the fluid. You need to visualize that fluid wave which is going posteriorly, and when it reaches the other end, you need to go to the other pole of the nucleus and then give the gentle tapping in order to release that fluid so that the hydrodissection will be complete.
so hydrodissection
So I'm just going to break down the steps of the hydrodissection into 4 steps. Step 1 is gentle tenting. A blunt hydrodissection cannula is placed inferiorly at the anterior capsular rhexis margin and is used to tend the anterior capsule away from the cortex and is then slowly advanced near to the equator of the lens. At this step, we are not injecting any fluid. Now coming to the second step, which is the slow injection of the fluid. Maintaining the tainted up position itself, we are going to inject the fluid gently. This results in a short posterior fluid wave, which creates a pressure gradient, which is the P1 and P2 is the pressure gradient which is seen inside the capsule and outside the capsule. And this creates that small wave between the anterior capsule and the cortex first. Next is step 3, in which there is a rapid pulse injection of the fluid. Posteriorly, this leads to a bulging forward of the entire lens due to the fluid trapped by the firm equatorial corticocapsular connections. This can lead to a temporary intraoperative capsular block syndrome, and it is characterized by an enlargement of the capsular rhexis diameter when we are looking at it. And then comes the last step, which is the step 4, which is the pressing down of the central portion of the lens much posteriorly. You need to put a little pressure over here in order to relieve that capsular block, forcing the fluid to come around the lens equator from the other end. So this constricts the capsular rhexis, and the capsular rhexis goes back to its original size, and it also mobilizes the lens. So hydrodissection and this capsular decompression, these two steps can be repeated in the opposite distal quadrant also, and may be followed by a hydrodelineation if required. Adequate hydrodissection at this point can be demonstrated by the ease with which the nuclear cortical complex can be rotated by the cannula. So now let's see the steps in detail in this video.
Establish a cortex cleaving hydrodissection plane for free flow, rapid injection for the hydrodissection, pressing down to neutralize the capsule block. And the more work you do with the hydrodissection, the less work you have to do in rotating the nucleus subsequently. So it's nice to go to the other side and repeat stages 3 and 4, ballotting the nucleus to make sure that it's free. Establish a cortex cleaving hydrodissection plane, slow injection for free flow, rapid injection for the hydrodissection, pressing down to neutralize the capsule block. And the more work you do with the hydrodissection, the less work you have to do in rotating the nucleus subsequently.
So while doing the hydrodissection, one tip which I would like to give is keep the posterior lip of the incision pressed with the cannula in order to allow the fluid to come out easily from the eye during the hydrodissection. Also, a gentle tapping of the nucleus will not do. You need to press it down and let the fluid come out from the other end. So if you're having a harder cataract or if it is a small pupil, you'll not be able to see that fluid wave. So in such cases, the anterior movement of the lens is a substitute sign for the fluid wave. So hydrodissection, many of the people, especially the beginners, usually think that this is a very easy step, and they don't give that much importance to this hydrodissection. But when you go into practice, you understand that not only CCC, everybody thinks that the CCC is the most important step, and if you have mastered CCC, you're good enough with phaco. But there are certain steps like hydrodissection which makes phaco much easier. Hydrodissection, if you do a very good cortical cleaving hydrodissection and a good rotation of the nucleus, the rest of the steps of the phaco, like the cortex removal, the quadrantic removal, everything comes up very easily and it's very time saving. So try to understand these basic steps and try to do it and practice. Coming to hydrodelineation, this hydrodelineation means you are separating the endonucleus from the epinucleus. Thus, this process will allow us to have a smaller endonucleus, which is easy to chop, less phaco power, and less time is required. While the epinuclear cushion will remain separate and will protect the posterior capsule during all maneuvers. So hydrodelineation is like a savior when it comes to softer cataracts. So initially, all the residents and all the novice cataract surgeons will face difficulty mainly with softer cataracts. But if you are going to do a very good hydrodelineation, that endonucleus will pop out easily and it will be very easy for you to do. And you will not finally end up with saucerization if you practice hydrodelineation well. So let's see how hydrodelineation should be done.
Easier, you go ahead and press the cannula into the substance of the nucleus. Usually I prefer to do it at the edge of the rhexis, so that is usually the size of the endonucleus. You go ahead and press the fluid and you see this golden ring. The same step is being demonstrated in the second case. You go ahead and place the cannula into the substance of the nucleus and then inject fluid and you have this golden ring. So this ring indicates the demarcation between the endonucleus and the epinucleus. Easier.
Now coming to the errors and remedies in hydrodissection. So if you're still facing some stress while rotating the lens, that means you have an incomplete hydrodissection. Remedy is to repeat the procedure. And this one happens mainly with new beginner surgeons, that is inadvertent placement of the irrigating cannula beneath the iris itself. It is just top of the anterior capsule and not beneath the anterior capsule. So what happens is this can happen even with small pupils also. This results in the injection of the fluid directly into the sonular area over the vitreous phase and into the posterior capsule. This can result in the shallowing of the anterior chamber and that can lead to a fluid misdirection syndrome. And sometimes you push the fluid too much rapidly or you do too much of hydrodissection that can lead to prolapse of the nucleus partially or wholly into the anterior chamber. But this situation can be managed easily by gently repositioning it into the Sinskey hook or by injecting little visco and pushing it back. Debulking the nucleus by chopping or sculpting may also be required in certain cases. Coming to anterior capsular block, this happens with overzealous fluid injection and capsular block. I think the next speaker is going to detail about this. So I'll just skip this. Coming to modifications of hydrodissections. So now we have a multi-quadrant focal hydrodissection, which is injection of small quantities, very small quantities of fluid focally in multiple quadrants. But this is very useful when it comes to cases which are having a corticular capsular adhesions, complicated cataracts, and in cases when you are suspecting some sonular weakness. Similarly, the usual thought was like, usual study, what school of thought was like, in posterior polar cataracts, you should not do hydrodissection, you should do only a hydrodelineation. But Fine et al. Has described a technique which is known as a multi-quadrant hydrodissection itself for posterior polar cataracts. Here he is injecting very tiny quantities of fluids injected gently at multiple quadrants such that the fluid wave is not allowed to spread across the entire posterior capsule. Thereby, it is still sparing the area of dehiscence. And then we have a minimal water jet. Minimal water jet means it's high speed pulse injection but very small quantity of 0.1 cc of liquid. Then we have a phaco sleeve assisted irrigation assisted hydrodissection, where we're using the phaco tip to intentionally vacuum the intraocular fluid in order to induce an irrigation dynamic pressure for the cortical capsular cleavage. So after a hydrodissection, the next step that we all do is a rotation of the lens. And I think many of them don't want to do this step, and many of them directly go to the sculpting. Maybe when you are an experienced surgeon, that will be fine. But in the initial stages, I think rotation of the lens is very important, because if you are doing a good rotation in both clockwise and anti-clockwise direction, it will loosen up all the cortex, and the other steps like the epinucleus removal and the cortical removal becomes very easy. So before rotating the lens, inject the whisker for forming the chamber and try to rotate both clockwise and anti-clockwise to loosen up the cortex. So this is one of my videos. Here, I am rotating it multiple times in order to loosen up all the cortex, because for me, I feel like if I spend a little time over here, it is fine, because the cortical removal becomes very easy after this. So that's all about hydrodissection and rotation of the lens. Thank you.
Thank you, Dr. Rakhi. That was truly wonderful, and you made it very clear. And as you rightly said, hydro procedures are also very important, along with capsulorhexis. So, I would like to ask Deepak sir for his comments.
I think can we talk about this everything after the other talk, because it's going to be mixed, the complications. It would be better, I guess. Anyway, congratulations, Dr. Rakhi. You taught us very well the anatomy of the lens and the steps in detail. Thank you so much.
Thank you, sir.
So moving on to our next presentation. So our next speaker is Dr. Ankit Agrawal. He works as cornea and phaco-refractive specialist at Eye Clinic Prayagraj. He has experience of over 10,000 phacos and MICS cataract surgeries in his private practice. He has presented multiple paper posters and invited talks at various national and international conferences. He has received ST Athavale Award for the best paper in neuro-ophthalmology at AIOC 2018. He has also received Best Paper in Session Award winner. He has also been the Best Paper Award winner at UPSOS Conference in 2021 and DOS International Hybrid Conference. He has special interest in disseminating the tips and tricks of phacoemulsifications to all the budding surgeons. Over to you, sir.
Thank you, ma'am. Now sharing my presentation. Is it visible? Can you hear me?
Yes, yes, you're audible. I think it needs to be in full screen.
Yeah, I am just putting full screen. Is it full screen
Yes.
now?
Yes, absolutely. You can go ahead.
Okay. Thank you. The topic is contraindications and complications of hydroprocedures. So as Dr. Raki has previously spoken, most of the things are similar. So I'll just skip to the types of hydroprocedure with hydrodissection and hydrodilation by just telling that hydrodissection is basically between the lens and the crystalline capsule, and the dilation is between the 2 points in the same lens, that is between the cortical matter and the epinucleus and the nucleus. So the most important tip I would like to give all the young surgeons here is to do hydrodissection using the proper cannula. See, what I see in practices that any cannula is just used to do hydrodissection. What I would like to emphasize here is that a 27 gauge hydrodissection cannula, which is flat at the end, gives a very good control over the amount of fluid you are ingressing in the eye, as well as using a 2 cc syringe is very important. Don't use a round needle for it, because sometimes the round needle you may not be able to put beneath the capsule and in front of the cortex. And the round needle sometimes may puncture the capsule as well while doing the hydrodissection. So use the proper hydrodissection cannula. Now I will share one video where I'm doing hydrodissection procedure. So after finishing the rhexis, now one important tip here is that always do the hydrodissection using the main port. So first I do some irrigation in the AC, so to remove all the viscoelastic which is there. Now some amount of hydrodissection is already done because the fluid has moved in. And now I'm doing some hydrodelination. As you can see, a ring formation in the nucleus, which is clearly visible here. While doing this procedure, continuously keep pressing the nucleus after every few cc's, ml, 0.1 ml of fluid injected in the eye, because that way you will remove the water which has gone behind, and protection from the capsular blowout is there. I will explain about it in the later slides. Now, the first topic, that is contraindications for hydroprocedures. So most of the contraindications for hydroprocedures are all relative contraindications now. Earlier, we used to be taught that we don't have to do this, but now various techniques have come up, and hydrodilation can be done in places where hydrodissection is really contraindicated. Example of common things are posterior polar cataracts. If the rhexis is already run out, and if it's an incomplete rhexis, that is, you have a big tag somewhere. So in those cases, hydrodissection, we were taught in the beginning of our careers that we should not be doing. But a slow hydrodissection or a hydrodilation can be done in these procedures. Sometimes you may encounter a posterior polar cataract. We have to make sure that the posterior polar cataract does not have a pre-existing big posterior capillary defect. Here, if you see carefully, you can see a posterior capsular defect here. This is important in the superior, at the 11 o'clock position approximately. So in this case, I did not try to do any hydrodissection. I show how I manage this. First, just staining the anterior capsule. After doing the rhexis, without doing hydrodissection, I just started my phaco at very low parameters. My bottle height was something around 25 or 30 centimeters here. And I was doing aspiration at 100 vacuum and aspiration at 10 or something. Just trying to aspirate whatever I can using minimal power and minimal fluidics. So this way, I'm just removing the bulk of the nucleus, leaving behind the cortical area beneath. Now, slowly using my phaco probe only, I will eat up the peripheral nucleus, just leaving the cortical area for the last, the posterior polar area for the last. Now, just using my IA, because it's a soft cataract, he was a fairly young patient, approximately 35 years of age, just eating up the cortical matter. Because subincisional, I was not able to reach using my phaco probe. Even the nucleus matter can be just aspirated using IA. Now, I can, if it is visible here to the listeners, can you see a small tear? It's extending from superior side to the inferior side. It's about approximately 3 mm thick and extending from the whole vertical meridian. That is the tear I was talking about. So here I will just keep putting viscoelastic behind the cortical matter or the soft nucleus here, so that it does not go in the vitreous. And I'll just use very low vacuum and low aspiration to eat up all the nuclear matter. So all the nuclear matter is removed. And very important tip for all beginner surgeons here: before removing your irrigation probe or the phaco probe from the AC, try to fill the AC with viscoelastics so as to keep the pressure reduced, especially in case of compromised capsules, because we don't want to allow the vitreous to come in the AC and disturb the anterior vitreous space. Now we can see the tear clearly. Now a 3-piece IOL can be put in the sulcus here, and the case can be salvaged quite better. Now coming to other complications, that is the anterior capsular tear. It can be due to the cannula putting pressure on the anterior capsule, or if there is some discontinuity and rhexis at some point. So this is important. And if you notice discontinuity in rhexis, if you find anterior capsular tear is happening, stop ingressing the fluid, fill the AC with viscoelastic, and try to solve the anterior capsular tear using your microaccess forceps. Or if you cannot, try to bring the nucleus in the AC so that it's not putting more pressure, and try to do, if you're doing manual, if you're trying doing phaco, try to do phaco in under very low parameters. Coming to the posterior capsular tear, when you don't notice the anterior capsular tear happening, the same can extend to the posterior capsule with the ingress of fluid not stopped in time. Coming the most important, that is the intraoperative capsular box syndrome. This is this video is courtesy Deepak Negur's YouTube channel, and it's a very important complication. It has happened to me multiple times in the beginning of my surgical career, and this video is very well explanatory. So when we are putting the fluid below the anterior capsule, the fluid collects beneath in the posterior part. Now, if there is no pressure in the AC and the rexis is slightly smaller, or there is a lot of viscoelastic fill in the AC, then the fluid keeps collecting there in the posterior side. And we, as per the anatomy of the lens already explained, that the posterior capsule is thinner than the anterior capsule. So what happens here is that after too much excess pressure, this posterior capsule can give up, and thus occurs the blowout, which is also known as intraoperative capsular block syndrome. So that's why when I was telling in my earlier slides that always try to use 2cc cannulas, always try to use thin 2cc syringes, try to use thin cannulas, the 27 gauge hydrodissection cannulas, and use little amount of fluid to do the hydrodissection. When doing the hydrodissection, try to egress out some of the viscoelastic from the AC. This allows the nucleus to move forward and give the space to the fluid which is behind, preventing the blowout. What happens when the blowout occurs is that you will see something called pupil snap sign. In this, the pupil suddenly becomes smaller, and this is called as pupil snap sign. We have to realize this when doing the surgery, because when the pupil snap sign has occurred, and after that, if you put the phaco inside in the anterior in the anterior chamber and switch on the irrigation, suddenly your nucleus will drop in the vitreous. So the salient points of this was we have to attempt hydrodissection in intact capsule only. For beginners, hydrodilation can be attempted, but very slowly so as to not to put too much pressure on the already compromised capsule. They have to remove bulk of viscoelastic from AC before hydroprocedures so that the fluid has space below the nucleus by lifting it, thus preventing a posterior capsule blowout. We should use main port for all hydroprocedures, thus space available for excess fluid to escape. And we can also press the posterior lip for further escape of fluids. We should use a small syringe, preferably a 2 ml and a 26 gauge or 27 gauge hydrodissection cannula for all hydroprocedures, thus giving controlled fluid ingress. Thank you.
Thank you, sir. That was a wonderful presentation. So I request Deepak sir for his comments and all the tips for hydroprocedures.
Congratulations, Ankit. Thank you for sharing your experience and highlighting all the important tips and few pearls. So I think he has highlighted most of the things. So the most common mistake which most beginner surgeons, okay, let me start from made some notes because we are involved in training a lot of youngsters, and the most common mistake what had happens is apart from the inappropriate positioning of the cannula, they don't know how much of a pressure is required to push, and that goes in and causes this cortical cleaving hydrodissection. So how much of resistance this you have to feel, and there's no other way. You have to just keep on having your analysis as you do it. So that is one important thing. And most of the times failed hydrodissection is probably the most important complication of hydrodissection, because that has not been talked here. I just want to highlight most of the novice surgeons, they don't even know that the hydrodissection has happened. They just go inject fluid somewhere and they comes out, and the fluid actually comes from the anterior part. They misinterpret it as got from posterior part. They inject fluid, it hits the equator, comes back the same plane. It has never crossed beyond the equator and gone. They flee a fluid wave. That fluid wave is actually from the anterior part, and they think it is done and they start rotating. So first, having an impression like how much of an pressure is required to go across, that itself requires some amount of experience. And it is more tougher in actually softer cataracts. because everything is so soft and mushy. You don't know where they are. Invariably, most of the beginner surgeons don't get the cortical cleaving hydrodissection. They just inject it goes in the cortex itself. Cortical cleaving hydrodissection, it has to be under the capsule. It doesn't happen. Most often than not, inject directly into the cortex. So you have cortex is separated from the endonucleus, but the cortex is still attached to the capsular bag. It is never separated. This is the most common complication which happens. But it is forgiving. That's not an issue. The most important point what I want to highlight is where do you position your cannula? I think if Dr. Raki, you could just go back to your video, the second video you showed of by Dr. Bruce Allen. Okay. Just open that video and pause the frame. I'd just like to highlight few things there. So if you place the cannula directly opposite to your incision, that is not the best way to do hydrodissection. The chances of inducing capsular block is very high. Okay, you can make this full screen. Okay, just pause here. Just pause here. Don't play. Just pause it here. Now, most common mistake what people do is now look at the position of the cannula. The surgeon is sitting temporally. The cannula is placed at around 5 o'clock. Okay. So the most common mistake most beginner surgeons do it. They place it. Even this is not so ideal, but it's all right. But most common mistake what people do is they place the cannula at exactly the opposite end. That is 6 o'clock. You're sitting temporally, maybe exactly the nasal end, distal end. So the cannula is directly abutting against the entire span of the nucleus, and you're injecting the fluid at the distal end. So what happens here is when you pass the fluid out and it has come out, actually the nucleus comes out, okay, comes out, and you are at risk of blocking the nucleus. Okay, and if you don't do a posterior decompression at that point, what happens is there is a higher chance of building of the capsular block syndrome. So that's the reason the best position to do hydrodissection to minimize the chance of capsular block syndrome would be to place the cannula at, I would request you to show the mouse at maybe 90 degrees to the main incision. Okay, 90 degrees or maybe 100 degrees to the main incision. That is with the mouse you can show the position. So during at 90 degrees, that is at 3 o'clock from the main incision, 3 o'clock from the main incision, or 9 o'clock from the main incision. So these would be the ideal sites to do hydrodissection. And then even if the nucleus tilts up, you have to go to the opposite quadrant and decompress it. So my recommendation is directly avoid it, placing the cannula directly opposite to your wound. Because here, if you prevent the nucleus from popping out, and there is a higher risk of inducing capsular block syndrome. So anywhere between maybe 3 o'clock to 5 o'clock would be ideal, or the other way around 9 o'clock to 11 o'clock, but avoid directly from the distal end, the 6 o'clock. So this is one way to minimize a capsular block syndrome. Most beginner surgeons don't understand this, and they end up causing a lot of building up of pressure inside the bag and invariably cause PC tears, which they don't diagnose it eventually at this point. So this is one important point which I'd like to highlight. Is there any other questions we can discuss?
So we'll take up the questions from the residents. Dr. Neil, you can unmute yourself.
Thank you so much, Libby ma'am. Firstly, thank you, YOSI team, for giving me this opportunity, and I am incredibly obliged to be learning today from the best mentors we all junior residents think of operating under. So being just a second year resident, I have a very basic doubt. As Bhavya sir mentioned towards the start, the temporal incisions are causing less astigmatism. So as a beginner surgeon, SICS surgeon, is it advisable for us to get accustomed to start doing temporal scleral incisions instead of a superior scleral incision? That is what I was thinking of.
I think would Meghur sir want? Is the question for Meghur sir?
No, no, you can, Bhavya, you can answer. If there is anything else, I'll add on later. Go ahead.
I'm sorry. Just once again, just can you repeat the question once again?
Sir, as a beginner surgeon, manual SICS surgeon, is it advisable to get accustomed to start doing a temporal scleral incision instead of a superior scleral incision?
To be honest, I would not suggest you that. Somehow, I personally believe that our own training has been like SICS always superior, because there's this huge area which is uprooted, which is open. You're planning to put in PMMA, you are putting an air bubble, you are leaving the sclera entirely open. So, just for the sake of practice, you need not shift to a temporal SICS. SICS, you can learn it and you can, continue doing it superiorly, because that is a better way practically to go across it. Eventually, when you are going to, upgrade to phaco, we are going to start learning phaco. It's not going to be that difficult to shift your positions once the surgical maturity or once decent amount of numbers start. Instead of that, I would, rather start giving you some tips, like we have our residents who, instead of holding it with a limbs or with a tooth forceps, they make another side port and put a dialer inside or an iris repositor while they are doing a rexis. So there are some, some tips which you can already incorporate in your training program to prepare you from the eventual phaco that you are going to learn. Temporal SICS, Filhal, I would not push you to do that. Matlab, I would
Okay,
not
sir.
recommend, to be honest. I mean, the house would give their opinion, I guess.
Thank you so much, respected sir.
Yeah,
Deepak?
yeah, Dr. Neil, what is your current expertise with SICS?
So very basic, sir. Like I'm still trying to go in detail with each step of the
Okay.
breaking down SICS into different steps and
Have
mastering
you
one.
started doing surgeries? Have you started doing surgeries?
Yes, sir.
Okay, you're doing superior SICS now presently.
Yes, sir.
Are you comfortable with the tunnel and other things?
Yes, sir. Frankly speaking, I have done probably one or two premature entries right together, itself right now. But yes, I am comfortable, sir.
Yeah, see, of course, premature entries, if you're done only, then you're a surgeon, okay? That is, otherwise, no surgeon. You cannot be a surgeon without doing premature entries. It's good that okay, so you started it. See, the reason why we do superior is a little bit more comfortable because we're so dependent on the superior traction suture. Are you putting superior traction suture?
Yes, sir.
Yeah. See, there is a mind block that we cannot do SICS without superior rectus traction suture. That's the reason why we all end up doing the superior incision. Why temporal incision is slightly difficult for a beginner is there you are doing without the help of a superior rectus suture. Okay.
Okay, sir.
But eventually, I would recommend that you have to transit to a temporal sclerocorneal incision eventually, you are for SICS, because the outcomes are so fantastic if you can achieve a temporal sclerocorneal incision and do an SICS. Their results are almost comparable to that of phaco because, as Dr. Bhavya has told, the amount of SIA which we can induce from a temporal incision is significantly lesser. So even a 6.57 millimeter temporal incision will not induce more than 0.75. So actually, it is the best refinement of SICS what you can do. If you can do that, the results will be almost indistinguishable from phaco. So I urge you to start doing it, but not now. Once you get a certain hang of it, okay? Just get a good hang of your tunnel. Have enough complications with your superior incisions and learn to manage them well, and then shift to temporal SICS. Temporal SICS should be your ultimate goal. The
Okay, sir.
timing when to switch it based on you, how good you are, at what stage you are, and when you get reasonable amount of confidence, you should switch. And when you do it, let me know your first case. It would be very good. Okay.
Okay. Thank you, sir. Thank you so much.
Thank you, sir. Dr. Neil, do you have any more questions? So we also have Dr. Juhi in the residence corner. Dr. Juhi, you can ask your doubts now.
Good evening, everyone. I want to ask, sir, how to avoid capsular block syndrome, because I have experienced 2 to 3 episodes of capsular block syndrome in my cases. So I want to know how to, well, like at my level, at a PG level, how can we avoid such situations?
Dr. Ankit, you can start. I'll just add on if anything is there.
So, Dr. Juhi, as I told, first is the first and most important, try to do a decent sized rexus, a 5.5 to 6 millimeter rexus. In the beginning, you don't need a very small rexus to do the surgeries. Secondly, do the hydrosection using the main port because you want to give the space for fluid to egress out from the main port. Thirdly, before starting the hydrodissection, try to remove some amount of viscoelastic which is already in the AC to create space for nucleus to move forward when you are putting the fluid behind the behind the capsule because it will move back to behind the nucleus. And very important, as Sir told, try to do the hydrodissection at the temporal point from the incision. That is, if you are doing from the temporal side, you have to do hydrodissection at the 9 o'clock, 3 o'clock, 1 or 2 diameters above and below, 1 or 2 clock hours above and below. If you're doing from the superior side, you have to do it from 3 and 9 o'clock, right? And very important also, try to do less amount of fluid. When I started doing my surgery, I used 0.5 millimeter of fluid for hydrodissection. I did not use even a 2 cc syringe. 2 cc syringe filled with 0.5 millimeter of fluid. I was doing hydrodissection with that. I used to come out, I used to fill it again, 0.5, I used to go in again. Like that I was doing. So that because I did not have that much good control on my hand that I will not press that much fluid inside. So in the beginning, I was doing that. You can do that also. That helps. And keep pressing the nucleus from sides so that the fluid which is collected behind is coming back up. This reduces the pressure on the posterior capsule and the block syndrome is reduced.
May I ask, why did it happen with you? What do you think? What is your analysis? Why did the capsular block syndrome happen in your case? When did it happen?
Dr. Juhi?
Hello, am I audible?
Yeah,
Yes,
yeah.
you're audible.
Yes.
So, I think in my case, it was the pressure that I was putting. I was putting a lot of pressure while injecting the fluid. So, it could be one of the reason.
Okay. So actually, if you could go back and see your own recordings, if possible, just go back and analyze. But as Ankit highlighted, first thing is always size of rexus. Use bigger is always better. Okay. And second would be where you're positioning the cannula. And always when you're doing it, always press on the posterior lip of the incision. Never place the cannula opposite your main incision and use very little fluid. As Ankit was telling, just 0.5 ml is good enough. So if you're using more fluid, that means that you're not in the right plane. There's a reason the fluid is getting wasted. So try to be mindful of where you're positioning the cannula. In the sense, it should be under the capsule and reaching as far across towards the equator as possible. If you're in the right position, you would require very less amount of fluid and then you don't have to use more pressure at all. Okay. So we understand it is a tricky step and only experience will tell, but you can cut short your learning curve if you're mindful in all the minute details. Okay. When you do this.
Okay, thank you, sir. Dr. Juhi, do you have any more questions to ask?
No, ma'am, thank you.
Dr. Anujit, would you like to add anything on incisions and hydroprocedures?
Nothing much. I would just like sir to elaborate two things. One is hydrodissection in cases of small pupil. Not that residents are picking small pupils, but because sometimes the pupil tends to become small during the initial steps. And especially hydrodissection after we remove the endo and epinucleus, sometimes the epinucleus does not want to cleave out. What would be his statement when it comes to cleaving the epinucleus post removing the endonucleus?
Yeah, the second question I'd like to begin with, the endonucleus part. So, what happens? That is the reason why nowadays we are not advocating hydrodelineation as much, frankly speaking, because now residents struggle to remove the epinucleus part. So that becomes a struggle, and most of the PC tears happen during that stage. So hydrodelineation to be done only in very soft cataracts where you find it's very difficult. But the good thing about hydro procedures is whenever things get stuck, you can always go and repeat it. There's no contraindication for repeating hydro dissection or hydro delineation as long as the rexus is intact. Now, suppose as Anujit is telling, if the endonucleus is stuck and you're not able to do, just go back and use your syringe to just keep on doing hydro procedure, repeated multiple quadrants. Eventually, the endonucleus just folds on itself. Then you get a grab and then hold it and pull it. Okay, so somehow get to ensure that it comes out. The second tip would be, suppose in a situation where you are unable to get the endonucleus out, especially the epinucleus out in the subincisional area. Somewhere getting the access to the distal part of the epinucleus, you're pulling it out. Endonucleus part, you're having it struggling, especially in posterior polar cataract or something. In that, the trick here would be uh, the the anatomy is the cortex is there, and after that, epinucleus is there. But you can't access the epinucleus. So what you do is hold the cortex and strip inside. What it does is it displaces the epinucleus inside. Then you got an access. Once it is displaced inside, put viscoelastic, then push it much more inside, and then go back with your phaco probe and then aspirate it. It's as simple as that. So don't try to hunt the epinucleus with your phaco probe, because what happens is you go and get a chew it out, and there's a risk of chewing out along with it the posterior capsule as well. So always remember that when you don't go and hunt for the epinucleus, displace it into a central safe zone and then go in with your uh, phaco tip to aspirate it. So to displace the subincision epinucleus, strip the cortex. When you strip the cortex, along with the cortex, the epinucleus also gets stripped and displaced. But you can't aspirate the epinucleus with your bimanual IA probe because it is very tiny. You can't aspirate the epinucleus. So once it is displaced inside, now you're in the safe zone. Now you go in with your phaco probe and aspirate it. Okay? So remember, whenever you're stuck with your epinucleus, repeat hydroprocedures, do viscodissection, and don't go and try to hunt for epinucleus with a bigger phaco tip probe. It can be deleterious, especially because the beginner surgeons don't have adequate control of the foot power, foot control. So that's the reason you may end up, causing a PCR.
Just one point on that, sir. So sometimes can we go and if the epinucleus is not cleaving, rub it with the irrigation probe as well? Does that help make the situation a little bit
You
easier
can do that, but ultimately some amount of fluid has to seep in between the
in the test?
nucleus and the capsule. So you have to make the fluid reach, because that's what is going to separate it from this. So use your irrigation cannula, use your hydrodissection cannula, whatever it is. Just try to do it. And in the worst case, try viscodissection as well.
Right.
The principle is displace the epinucleus into the central safe zone. Don't go hunting with your phaco probe.
Right. And hydro procedures for small pupils?
Yeah, small people, you have to rely on your tactile sensation, because you don't know where the cannula is going now. Okay, because you are unable to visualize the rexus margin. So you have to go there and you have to feel for the nucleus, and feel for the nucleus, that then you hope that you are not above the capsule and you are below the capsule. So that's a tricky situation, and the only solution is experience, and you have to rely on your tactile sensation. And how do you diagnose this? You have to notice the displacement of the nucleus. Slight forward displacement, that should be enough. That is an easier thing to appreciate. But the problem is where your cannula has gone. Is it above the capsule? Is it under the capsule? And that is a tricky situation. And invariably, you will know that when you're tenting the capsule, get the feel that you are under the capsule, but above the nucleus, and it's a safe. And that's a feedback which you have to get from your hand to your brain, and that should be the only clue there. There's no other visual clue for you. To assess the completion of the hydrodissection, the nucleus comes up. That is a visual clue. But to know whether the cannula is in the right position, the tactile clue is the only thing which you have to rely on.
Right, thank you, sir. And one last question. So especially in NS1 grade cataracts, when we go in for our first stage of hydrodissection, the nucleus pops out of the bag. And then in many cases, we just try and do a chip and flip and just rotate the nucleus out of it. So for beginner surgeons, do you feel that that is a good technique, or would you advise in these cases to put the nucleus back in the bag and go for a stop and chop?
For a nucleus 1 grade cataract, which is very soft, it's okay to emulsify in the antechamber. It's perfectly fine. So you just put OVD again, replenish OVD, and then keep nibbling at the nucleus, entire nucleus. Don't try to chop or do anything. Just eat the entire nucleus as it is. So if I don't want the second hand instrument to do some maneuvering, and that is going to cause more damage to the endothelium because the beginner surgeon's control is not so great. Just go and try eating off. That's all. Just finish it off in the quadrant removal mode. So when you try to divide and chop, it's first of all soft. That is going to cause more problem to the endothelium than anything else. If it is popped out, you just go and eat. But if the nucleus is grade 3 or plus more, I would not recommend this. I would go back, put the nucleus back into the bag and then eat it. And then do the conventional phaco.
Right. Thank you. Thank you so much, sir.
One more highlight, whenever contraindication for hydrodissection is if the rhexis is not continuous. Remember, if the rhexis is not continuous, it is a contraindication for hydrodissection. Because if you do hydrodissection when the rhexis is not continuous, there's always a risk of the tear extending beyond the equator going into the posterior capsule. So no hydrodissection if the rhexis is not continuous. And believe me, if without hydrodissection also, you can emulsify most cataracts. Although hydrodissection, we tell it's very important, but in certain situations we do manage, and it can be managed quite effectively without hydrodissection as well.
Right. Thank you so much, sir. Back to
So
you.
regarding the
Yeah.
incision, especially for the junior residents, when they're shifting from the superior SACS incision to a temporal SACS tunnel, usually most of them face difficulty with the positioning of the incision, and they will have iris prolapsing out in most of the cases, especially when they are trying to deliver the nucleus. The iris comes and tucks that tunnel. So what will be the tips in constructing a temporal incision for a
No, I
resident?
think the basic reason why the iris is coming out is your inner lip is not formed well. Okay, the corneal wall which is supposed to be there, it is not acting. So the same principles are here. And why the iris comes? Because invariably your incision is much more anterior entry. It is not going beyond the corneal wall and creating. That's the reason why the reason for premature entry also I'll tell you. Why the most surgeons have premature entry. The fundamental principle to avoid premature entry is when you're tunneling, the eyeball has to be turned away from the surgeon. It has to be turned away from the surgeon. That is what your superior rectus is doing. When you put a superior rectus, the eyeball is turned away. When you do that, when you do a tunnel, there is a lesser risk of causing a premature entry. When you are doing a temporal incision, and if the eyeball is looking straight ahead like this, and then you try to tunnel, there is a higher risk of causing a premature entry, which the surgeon would not have noticed. And then when you're trying to remove, the iris comes out. If you have a very well formed internal lip, there is no business for the iris to come inside. So the trick here is move the eyeball down with your second instrument when you're trying to tunnel and when you're trying to enter. So when you move the eyeball down, the risk of premature entry is minimized.
Thank you, sir.
Thank you, sir. So this brings us to the end of the webinar. I would like to thank Deepak sir for his valuable time. We all have been watching your videos, sir, right from the beginning of our journey in ophthalmology. And to get all the live tips and tricks from you is extremely incredible. We are extremely thankful from Team YOSI and Team Cataract Focus Group YOSI. I would like to thank Dr. Anujit for helping me in planning this whole series of webinar. Nilesh sir for always been a helping hand. He has currently joined through YouTube. He is having some technical issues in Zoom. Thanks to Dr. Rakhi, Dr. Bhavya, and Dr. Ankit for the wonderful sessions and talks they delivered. It was extremely helpful. Thanks to Dr. Juhi and Dr. Neil for connecting with us, and I think it was a great opportunity for you as well from directly asking your doubts from Dr. Deepak sir. So Deepak sir, any comments from you we would like any tips to improve ourselves or anything you would like to add?
No, you guys are doing a great job. Yeah, congratulations. So I wish we had such a forum when we were growing up. You're doing a great job. We need to learn from you guys.
Thank you so much, sir. Dr. Anujit, anything you would like to add?
No, I just wanted to add to what Sir said, and that he made the forum after thinking that we should have a forum. So we are reverse back grateful to you, sir. I think everyone over here and everyone listening in live has at least seen one, if not more, videos of you, including myself. So I think the birth of this cataract focus group, I think you are an instrumental role to play some way or the other. So thank you so much.
So
Right.
we'll take the mandatory photo before
Yeah,
closing the
and
webinar.
everyone can switch on their screens if you are able to. And this is the YOSI sign that we use for all the webinars. So yeah, right. Right. Okay. Thank you so much. Thank you. I think we can end the live.
Thank you so much. Thank you, everyone. Thank you, Deepak sir. Thank you, Numerotech team. Good night, everyone.
Everyone.
Good night.